Hope my voice is clear.
Alaikum salam, doctor. Yes, it's clear.
Okay, so let's begin with the lecture discussion. And so before starting with the discussion, I will make an important uh, instruction. Please, before the exam, you should go through all these slides, right? Now in the tutorial, I will discuss the important clinical information, right? So this important clinical information will be helpful to you in the clinical blocks. So I will focus on those information. But before the exam, you should go through all these slides of the lectures, which we have discussed at the time of lectures. So go through all. Right.
Recording in progress.
Right. See my screen. I have opened the lecture of tumors of the CNS. Can you see my screen?
Yes.
Yes, doctor.
Okay. So what we will do, we will go backwards, right? So because I think maybe in the exam the questions or I think the questions for the end examination will come more from the topics after the exam too. So we'll go backwards. So we start
Doctor,
with
I think only have the final part. And CNS, they deleted the other lectures. Only we have the new one.
Okay. So you only have the new one.
Madonna and 2 are excluded.
They are excluded. Okay. So you have lectures from which lectures? Can you just tell me the lectures?
Brain abscess.
Tumors, abscess, and cerebrovascular diseases.
Okay, these 3 topics. Okay.
The last 3.
So the last 3. Okay. So we start with brain tumors. And if you remember, in the brain tumors, we discussed the brain tumors. They are divided into 2 broad categories: the primary tumors and the secondary tumors. Primary tumors are the tumors arising from the brain, and secondary tumors are arising at somewhere else, and then they are metastasizing to the brain. And this is the classification of the primary brain tumors. First and foremost, the most important categories is the gliomas, that is the tumors arising from the glial cells. So in the gliomas, we have 3 important tumors: astrocytomas, oligodendrogliomas, and ependymomas. So we begin with astrocytomas. And if you recall, at the time of lecture discussion, we have discussed that usually we don't classify brain tumors into benign and malignant. What we do, we grade brain tumors. So, and as you know, there are 4 grades: grade 1, 2, 3, and 4. So the lower the grade, better is the prognosis. Higher is the grade, worse is the prognosis. So grade 1 brain tumors is equivalent to benign brain tumor. So we have 4 grades of astrocytomas: pilocytic, diffuse fibrillary, anaplastic, and glioblastoma. So we start with pilocytic astrocytoma. And we have briefly discussed this at the time of OSPE discussion as well. So it's a grade 1 tumor commonly seen in children, and the most common site is cerebellum. So in children, remember C for children, C for cerebellum. These tumors, they are usually cystic and with a solid mural nodule in the tumor. Microscopic features, we have already discussed: malignant astrocytes with hair-like processes, microcyst, rosenthal fibers. And these tumors, they have good prognosis, comparatively good prognosis, better prognosis. These tumors, they are slow-growing tumors. So fortunately, they are seen in children, so they have comparatively better prognosis, and they are equivalent to benign tumors. The next tumor is diffuse fibrillary astrocytomas. So these are grade 2 tumors, and these are the most common brain tumors occurring in adults. They are usually seen in 4 to 6 decades of life. The most common site. So remember, in adults, usually the brain tumors, they are seen in anterior fossa. So A for adult, A for anterior fossa. In anterior fossa, we know there are cerebral hemispheres. So the most common site for brain tumors in adult is cerebral hemispheres. So diffuse fibrillary astrocytomas commonly seen in cerebral hemispheres, but they can be seen in other parts of the brain as well. So these tumors, as the name suggests, diffuse, right? So these are diffusely spreading, diffusely infiltrating tumors. And you can look at the MRI image of the tumor. So this is a tumor, and if you look carefully, it is causing shift in midline. So the midline is deviated on the opposite side. And if you look at the borders of the tumor, the borders are diffuse, they are fuzzy. It is not well demarcated. So this is a diffusely infiltrative tumor. Then next, here, again a large mass, large tumor, shift in midline. Same here, shift in midline, a large tumor in this hemisphere. Now in microscopic features, compare this image with the image which we have seen for pilocytic astrocytoma. Pilocytic astrocytoma was grade 1, now this is grade 2. So in grade 2, the nuclear pleomorphism is more than the grade 1. So there is moderate amount of nuclear pleomorphism. So nuclear pleomorphism is the sizes and shape of nuclei. So the grade is moderate as compared to grade 1. And if you look at the background, the astrocytic fibers, they are fine fibers. So they are fibrillary. So that's why diffuse fibrillary from the name itself. The grade 3, remember as a general rule, grade 3 brain tumors, they are labeled as anaplastic. And in general pathology, long time back, you studied what is the meaning of anaplasia. Also at the time of lecture, I have discussed what is the meaning of anaplasia. Anaplasia means the loss of differentiation. So more the loss of differentiation, more aggressive the tumor is. So this is called as undifferentiated tumor. So anaplasia means undifferentiation or more degree of undifferentiation. Right. So here, that's why these tumors, they are called, they are grade 3 tumors and they are labeled as anaplastic. And now compare this nuclear morphology with the grade 2 tumors. So here the nuclear morphology is more severe than the grade 2. It is more severe. So more amount, more grade of nuclear pleomorphism. So compare, you should compare the images, right? So grade 1, grade 2, grade 3. So you can see the difference in the gradual increase in the nuclear pleomorphism, grade of nuclear pleomorphism. So from this, we can identify the grade of brain tumor. And a very important feature of anaplastic or the grade 3 brain tumor is presence of mitosis. So here in mitosis, we are seeing the nuclear division. And again, you need to use your logic. Grade 3, it means it's a highly aggressive tumor. So that's why it has more proliferative potential. So that's why it shows more of mitosis, more of multiplication of cells. The next is glioblastoma. So this is the ultimate, this is the final grade, and nothing can go beyond this. So if you look at the gross and microscopic features, you will find all the different gross and microscopic features which we have studied till now. Areas of necrosis, solid areas, cystic areas, degenerative areas, whitish areas, yellowish areas, everything, hemorrhage and everything is present in this tumor in gross. And even in microscopy, compare this image with grade 3. So if you compare this grade 4 image with grade 3, you can easily differentiate the difference. You can notice the difference between the nuclear pleomorphism. Extremely high grade of nuclear pleomorphism. Nothing can go beyond this. This is the ultimate, right? So you see nuclear features, like some of them, they are multinucleate cells. Some of them, they are having an abnormal shape. And additionally, they will also really, they will show the mitotic figures. So since it's a grade 4 tumor, so it is after grade 3. So grade 3 has mitosis. So additionally, plus this tumor has higher grade of nuclear pleomorphism, and two most important microscopic features which we have discussed at the time of hospital discussion is the large areas of necrosis and vascular proliferation. So again, you can correlate, use your logic. Large areas of necrosis, vascular proliferation, it means the tumor is very aggressive. Tumor is proliferating very fast. It is growing so fast that even the blood supply is not keeping pace with the amount of proliferation. So the tumor cells, they are dying because of lack of nutrition. And even the blood vessels, they are proliferating so fast that you will find large areas of vascular proliferation. So prognosis, this is one of the worst tumor known to occur in humans. It has extremely bad prognosis. The next is oligodendroglioma. So now oligodendroglioma, from the starting itself, they are grade 2. They are never grade 1. And these are second in frequency after astrocytoma. Again, commonly seen in adults from 4 to 6 decades. So the most common site will be cerebral hemisphere. Now, if you now compare the gross of oligo with the gross of grade 2 astrocytoma. So you will find, although it is grade 2, but it is well circumscribed. right? So again, from this, see, remember the similarities and remember the dissimilarities. From this, you can get important clinical information. So although it is grade 2, but it is well circumscribed. So in another words, this tumor has comparatively better prognosis as compared to grade 2 astrocytoma. Both of them, they are grade 2, but this one carries a better prognosis as compared to grade 2 astro, because it is grade 2 astro, it is diffusely infiltrative tumor. And this tumor, it shows foci of calcification, another important gross feature of this tumor. There are foci of calcification. And if you look at the microscopic features, very typical appearance. It has fried egg appearance and chicken wire capillaries. The next prognosis I already mentioned. The next is ependymoma. Ependymoma, again, from the starting itself, they are grade 2, they are never grade 1. Ependymomas commonly seen in children as well as in adults. In children,
Sorry for the
Yes.
microscopic feature. The first one is the chicken. Chicken what? Slide number 25.
yes, this is fried egg appearance, and this is
Yeah.
chicken wire capillaries.
Chicken what? Sorry again.
Chicken wire capillaries.
Okay,
At
thank
that-
you.
I think maybe you were absent at the time of lecture. So, at
Yes,
the time
I was.
describe this in detail. What is the meaning of fried egg appearance? What is the meaning of chicken wire capillaries?
Okay, thank
So
you.
if I describe now in the microscopic feature, I will not be able to finish the tutorial then.
No, it's okay. I just want to. I will read about it. Thank you so much.
Right. Now, ependymomas, they are seen in both in children as well as in adults. Now, in children, again, you have to use your logic. We said in children, the most common site for the brain tumors is the posterior fossa. So, in posterior fossa, now correlate ependymoma, right? Ependymoma arises from the ependymal cells. And in posterior fossa, which ventricle is present in the posterior fossa? In posterior fossa, you find fourth ventricle. So, the common site for ependymoma is fourth ventricle, that is posterior fossa in children. Now, if there is any tumor, if it is arising in the fourth ventricle, right? Fourth ventricle is a cavity. So any tumor which arises in the cavity, it takes a papillary structure, papillary shape. So again, from this you can correlate. Okay, arising in children in the posterior fossa in the cavity. So the tumor, it has papillary structure. Then next, the tumor is present in the ventricle. So what will be the clinical course? The tumor will block, it will obstruct fourth ventricle. So the patient will present with hydrocephalus. Then next, the tumor cells, they will enter CSF, and from the CSF, they will spread to different parts of the brain. So now you know that one of the mode of spread of tumor is via CSF as well. Right. Now regarding microscopic features, so these are the malignant ependymal cells. And again, here you see that the tumor cells, they are arranged in a gland-like pattern. These are called as rosette. And these rosettes, they are called as, there are two types of rosette, true rosette and perivascular pseudo rosette. At the time of hospital discussion, again, we discuss this, right? So this is a true rosette. It has a lumen, and this is surrounded by the the tumor cells around the blood vessels. So these are called as perivascular or pseudo rosette. The next clinical course I already discussed. In adults, this tumor arises from the spinal cord. But in the spinal cord, the tumor cells doesn't arise from the central canal, right? So that's why in adult, the prognosis of this tumor is comparatively better as compared to children. So you have to remember this clinical point. Now the next tumor is medulloblastoma. Medulloblastoma belongs to the family of small round blue cell tumors. So when I say this particular tumor belongs to the family of small round blue cell tumor, you should get all the characteristic clinical features of this tumor in your mind. And if you remember, in each and every block, almost we studied one tumor which belonged to this family. So these tumors, they are always malignant, they are always grade 4, they are seen in children. So now again correlate medulloblastoma seen in children. So in children, we know the common site is posterior fossa. In posterior fossa cerebellum. So this tumor exclusively arises in the cerebellum, and in the cerebellum, it arises in the cerebella verbis. We discussed the MRI and the gross findings at the time of hospital discussion. So as I mentioned, the morphology of the tumor, it is extremely cellular tumor, highly cellular, hypercellular tumor, and the tumor morphology is small, round, blue cell. The tumor cells are small, they are round, and they are blue, and they may also show a rosette, right? and these are called as fumarate rosettes. Now again, the clinical course exactly same like ependymoma. So this tumor, it may obstruct the flow of CSF, right? And it may cause hydrocephalus, and then it may spread via CS. And another important feature which is seen here is called as drop metastasis. So in drop metastasis, the tumor cells enter CSF, and from there in the CSF, from the fourth ventricle, they will drop down. They will directly drop down and they will involve chorda equina. So this is called as drop metastasis. And another important clinical feature of this tumor is it is extremely radio sensitive, right? And if you give radiotherapy, if you diagnose this tumor early, if you give radiotherapy, that tumor will melt away and the prognosis becomes excellent. The prognosis is very good. So early diagnosis is very important because this tumor is extremely radio sensitive, right? So these are contrasting features: highly malignant tumor, grade 4 tumor, but extremely radio sensitive. The next is primary CNS lymphoma. This is one of the common brain tumor which is seen in immunosuppressed individuals, particularly in patients suffering from AIDS and patients who are receiving immunosuppressive therapy after organ transplantation. And it is associated with Epstein-Barr virus, which we discussed at the time of lectures and also in the immune block. And the most common lymphomas which are seen here is the non-Hodgkin B-cell lymphoma, and the most common type is the diffuse large B-cell lymphoma. And these tumors, they have again bad prognosis. Even with chemotherapy, the response is very less, very poor response, and they are aggressive tumors. The next is meningiomas. They are always grade 1. So we can call them as benign tumors because they are always grade 1, and they are commonly seen in adults, more commonly seen in females. Exact reason is unknown, maybe because of expression of estrogen and progesterone receptors, which is seen in some meningiomas, and they are rare or uncommon in children. And one of the important predisposing factors which is associated with meningioma is repeated radiation to the head neck region. Of origin, from the name itself, meningothelial cells. Common site, the most common site is the parasagittal aspect, this area of the brain. Meningiomas can arise over the surface of brain as well as from the undersurface of the brain. But the most common site is the parasagittal aspect of the cerebral hemispheres. Gross we already discussed at the time of OSPE, microscopic we already discussed. Now the next are the metastatic brain tumors. So these are the most common primary sites from which the tumor metastasizes to the brain. In males, it is usually from the lungs. So particularly in chronic smokers, lung adenocarcinoma, squamous cell carcinoma of the lung. Then in females, breast malignancy, infiltrative ductal carcinoma of the breast, not specified otherwise, right? If you remember the name of the most common malignant tumor arising in the breast. So these are the two most common primary tumors which metastasize to the brain. Then next, melanoma arising from the malignant tumor arising from the melanocyte. Then next, renal cell carcinoma, and then adenocarcinoma from the colon and rectum, colorectal carcinoma. So these are the metastatic deposits, multiple metastatic deposits, usually seen at the junction of gray matter and white matter. And if you look carefully, there is a peri-lesional edema. So if someone is presenting with multiple brain lesions, high possibility that these are secondary brain tumors, and you should search for the primary tumor in the sites which we just now discussed. Now, these are the clinical manifestations of brain tumors. The most important manifestation will be presenting with the SOL, space occupying lesion. So we have discussed what are the features of the space occupying lesion: headache, nausea, vomiting, papilledema. Then next, destruction of the brain tissue will lead to focal neurological deficit, and it may also lead to abnormal firing of neurons, which leads to seizures. And the patient might present with herniation syndrome. There are 3 types of herniation syndrome: sulfalcine, transtentorial, and cerebellar tonsillar herniation. The next are the peripheral nerve sheath tumors. So we have benign and malignant. Benign, schwannoma, neurofibroma. Schwannoma, from the name itself, they arise from Schwann cell, commonly seen after the 4th decade of life. They may be either sporadic or associated with neurofibromatosis type 2. Common site, peripheral nerves of the extremities, head neck region, and from the sensory cranial nerves, particularly the vestibular branch of the 8th cranial nerve. And the common site is at the junction of the CP angle, cerebellopontine angle. Clinical manifestation in the form of, because of the compression of the vestibular branch of the 8th cranial nerve, patient will present with tinnitus, and it might progress to hearing loss. The next is neurofibroma. Again, it's a benign tumor, and it is a combination of all the cells which are present in the peripheral nerve sheath. We don't know the exact cell from which this tumor arises. So it can be either sporadic or part of neurofibromatosis type 1. The malignant counterpart of all this benign tumor, benign peripheral nerve sheath tumor, is called as malignant peripheral nerve sheath tumor, MPNST. And again, it's a highly malignant tumor. It is almost as, the same level of glioblastoma which we discussed. And this tumor, it frequently arises from the medium to large peripheral nerves. One of the common nerve from where it arises is the sciatic nerve, usually seen after the 6th decade of life. The next is the familial tumor syndrome. So here we have two tumor syndromes. The first one is neurofibromatosis type 1. The next one is neurofibromatosis type 2. Both of them, they are autosomal dominant. Type 1 is more frequent than type 2. You should know all the details about type 1. It is also covered in the OSPE examination. The next, in the pathogenesis, type 1, easy to remember, 111. So type 1 inactivation, like 1, the name of gene is NF1 gene from the name of the disease itself, located on chromosome number 17. Again, there is 1. So easy to remember, 1111. And this protein, this gene, it encodes a protein which is called as neurofibromin. So because of inactivation of these genes, there is no or very less production of neurofibromin, and the patient develops following features: neurofibromas, glioma of the optic nerve, Lish nodule, and cafe au lait or hyperpigmented macules. So these are the Lish nodules. The next is neurofibromatosis type 2, autosomal dominant, less common. Pathogenesis, again easy to remember, 222, NF2 gene, located on chromosome number 22. And here the abnormality is mutation. Previously it was inactivation, here the abnormality is mutation. And the gene, the protein which becomes abnormal because of this mutation is called as Merle protein. And here the patient has three important features. Number one, bilateral 8-nerve schwannomas, also called as acoustic neuromas. Acoustic because sound, right? So the 8th nerve is responsible for the hearing, for the sound. So bilateral 8-nerve schwannomas or acoustic neuromas. And the next is multiple ependymomas. And the third feature is multiple meningiomas. So again, look at the features. There are multiple tumors, right? So multiple schwannomas, multiple ependymomas, and multiple meningiomas. All right. So this was all about the brain tumor. Next, you said cerebrovascular disease, right?
Yes.
Can you see my screen? Cerebrovascular disease.
Yeah, doctor.
Okay. Right. So cerebrovascular diseases, they are the third leading cause of death and the most common prevalent neurological disorder. So you should know all the details about this condition. So if you remember, at the time of lecture, we discussed cerebrovascular diseases. Another name is cerebrovascular accident, and a more general name is stroke, right? Many people, they use this name, stroke, but stroke is a layman term. So the more proper technical name is either you use cerebrovascular disease or cerebrovascular accident. And we divide this into two broad categories: hypoxia, ischemia, infarction, and hemorrhage. Hypoxia, ischemia, and infarction, they form part of a spectrum, right? So we have hypoxia, ischemia as one subgroup, and another is infarction. So again, if you look at hypoxia and ischemia, sometimes it is very difficult to separate hypoxia and ischemia. So again, hypoxia and ischemia, they form part of a one single entity. So it is called as hypoxic ischemic encephalopathy. And the more extreme version of this is infarction, right? So in ischemia, there is decreased blood flow. In infarction, there is complete obstruction to the blood flow leading to necrosis. And the next subgroup is hemorrhage. All right. So now in hypoxia ischemia injury, again, we have two situations. One is entire brain is involved, and in another situation, a part of brain is involved. When what are the examples in which entire brain is in, like for example, cardiac arrest, shock, and then severe hypotension. So in all this situation, there is decreased blood flow to the entire brain, right? And clinically, again, if it is mild, so the patient will have just post-ischemic confusional state, some memory loss. And if it is very extensive, sustained decrease in blood flow to the entire brain. So the patient may land up in vegetative state or brain death situation. The next type is focal cerebral ischemia. A part of the brain is involved. So again, less blood flow, ischemia, complete obstruction, infarction. So what are the reasons for decreased blood flow to the part of the brain, or what is the reason for obstruction to the flow of brain? We have the following reasons. Again, so the first and foremost, most important reason is thrombosis superimposed on atherosclerosis. So patient already has atherosclerosis and then it gets complicated and the patient develops thrombosis. So there is complete obstruction to the blood flow. And the two most important predisposing factors are hypertension and diabetes mellitus. So if you go other way around, in patients who are suffering from both hypertension and diabetes mellitus, they have accelerated atherosclerosis, which gets complicated with thrombosis, and this leads to cerebral infarction. So there is high prevalence of cerebral infarction in patients who are suffering from hypertension and diabetes mellitus. So this is the chain, right? And what are the common arteries which are involved here? So these are the three common sites: carotid bifurcation, the next starting of the middle cerebral artery, and the third is the ends of the basilar artery. The next example which causes complete obstruction is embolism. Again, we'll discuss embolism at the time of OSP discussion. And what are the predisposing factors? Myocardial infarction. So other way around, patient who is suffering from myocardial infarction has a high chances of developing cerebral infarction. So this is the chain, right? Myocardial infarction will lead to thrombus become embolus, and this embolus goes and blocks blood vessel in the brain. The next is valvular disease, vegetations on the valves, subacute bacterial endocarditis, and the third is atrial fibrillation. We discussed at the time of OSP discussion. And the most common artery which is affected, which is involved, is the middle cerebral artery. What is the reason? We discussed at the time of OSP discussion as well as at the time of lecture. Then there are two types of infarct: hemorrhagic infarct or red infarct, and the next is non-hemorrhagic or bland infarct. All right. So either you write red infarct or hemorrhagic, or you write non-hemorrhagic or bland or pale infarct. Now, what is the reason for red infarct? We discussed it is because of embolism. What is the reason for non-hemorrhagic infarct? It is because of thrombosis. So because of thrombosis, there is complete obstruction, and because of complete obstruction, there is no partial lysis of the blood clot. So no blood enters in the infarcted area, and also there is no blood from the collaterals. That's why the area of the infarct is totally bland. That is called as non-hemorrhagic infarct. And the opposite is true for hemorrhagic infarct. So we again discussed this at the time of lecture. And what is the reason why we need to differentiate? Because there is an important clinical or therapeutic importance in this. In case of non-hemorrhagic infarct, that is because of thrombosis, we can use thrombolytic therapy. And this therapy is contraindicated if the infarct is because of embolism. So you need to remember this clinical information. All right. So again, this image we discussed at the time of lecture. So this is a hemorrhagic or red infarct. And after healing, if you remember at the time of lecture, we discussed that during the healing process, what happens in the brain, the healing is by gliosis. In other tissues, the healing is by fibrosis. But gliosis has limitations. Gliosis, it cannot cover the entire infarcted area. So if you look carefully, here there is gliosis, but the rest of the area, it has become like an empty cavity. Now what about microscopic features, early features? Within the first 24 hours, the most important feature is the presence of red neurons. So here you can see the red neurons. They are not exactly red, but they are more eosinophilic. They are more pinkish. They are dark pinkish in color, which resemble like red. So they are called as red neurons. And red neurons indicate that there is some ischemic injury or ischemic assault on the neurons. The next, in the first 24 hours, there will be entry of neutrophils. So now the neurons, they are dying because of the ischemia or because of the complete obstruction to the blood flow. Now the neurons, they have started dying. They become more reddish, right? More pinkish. So they are called as red neurons. And the first line of defense will be by the neutrophils. So now there will be entry of neutrophils. Now the next, after 24 hours, the neutrophils, they will be replaced by the macrophages. So the macrophages, they will come, or the microglial cells, they will become modified, they will become macrophages, and they will start engulfing the dead necrotic tissue. and after 2 weeks, the dead area will be replaced by gliosis. So again, if you look at this area, this is an area of gliosis, and this area of gliosis is a little bit more loose. So you see some empty spaces. It is more loose. It is not exactly compact like the normal brain tissue, and it only contains the glial cells. You don't find any neurons. So this is how the microscopic features which are seen in the infarct. In the early stage, red neurons. Then in the middle stage, there are macrophages, and in the final stage, there will be gliosis. So this was all about the first subcategory. Now the next subcategory is the hemorrhage. So when we say hemorrhage, it means we are talking about intracranial hemorrhage. So again, we divide this into two categories: spontaneous or non-traumatic and traumatic hemorrhage. So spontaneous, two types: intracerebral, subarachnoid; traumatic, epidural, subdural; then again intracerebral and subarachnoid. So in other words, intracerebral and subarachnoid can be either spontaneous or it can be traumatic. So first, intracerebral hemorrhage or intraparenchymal hemorrhage, commonly seen in middle to late adult life. Reason we have already discussed at the time of hospital: rupture of small intraparenchymal blood vessels. Predisposing factors are hypertension and cerebral amyloid angiopathy. Now, because of sustained hypertension, because of chronic hypertension, what happens? The small blood vessels in the brain, particularly which are less than 300 micrometer in the area of basal ganglia, they develop small microaneurysms, which are called as Charcot-Bouchard microaneurysm. And these aneurysms, they will rupture, and the patient develops intracerebral or intraparenchymal hemorrhage. So this is the pathogenesis of intracerebral hemorrhage. And the common side is, the most frequent side is the putamen. The next is thalamus, and the next pons. And the patient will develop neurological deficit depending upon the site which is involved. So this is the image we already discussed: intracerebral hemorrhage. Now this is massive. This is massive intracerebral hemorrhage. Now this hemorrhage, it has become more complicated. It has entered inside the ventricle, and also it has reached in the subarachnoid space. So this is intracerebral plus intraventricular plus subarachnoid, right? So it is all over the brain. The next type is subarachnoid hemorrhage. The most frequent cause for this is rupture of saccular or berry aneurysm, which we discussed at that time. So remember, S for saccular, S for subarachnoid hemorrhage. So these aneurysms, they are frequently seen in the circle of Willis. They are seen in 2% of the world population. Exact causes unknown. The reason for aneurysm is there is some genetic defect which causes defect in the tunica media. Basically, there is patchy defect in the tunica media. So because of this patchy defect, the tunica media is weak, blood vessel is weak in patchy areas, and in the area which is weak, it develops localized aneurysms, which are called as saccular or berry aneurysms. And a child basically is born with the genetic abnormality, but the aneurysm, they are seen in the adult life. Aneurysms, they are not seen in children, right? They develop in adult life. But the child is born with genetic abnormality, and that child who is born with the genetic abnormality, additionally, he smokes cigarette in the adult life, or he develops hypertension. Then these two factors will exaggerate. They will cause early development of these aneurysms, right? And we have discussed the important side. The most frequent side is the junction of anterior cerebral, anterior communicating artery. The next is middle cerebral artery, and the third is junction of middle cerebral artery and posterior communicating artery. So again, if you look carefully, so this is the third place where the importance of middle cerebral artery. Middle cerebral artery, it shows three important pathologies. Number one, it is the second frequent site for thrombosis with superimposed on atherosclerosis. It is the most frequent site for embolism, and it is the second frequent site for saccular or berry aneurysm. So understand the role, the importance of middle cerebral artery. So this is the actual image of aneurysm. So this aneurysm.
Case for the middle cerebral.
Pardon me?
Repeat it again for the middle cerebral artery.
Yes, three important pathologies. Second, the first is, it is the second frequent site for thrombosis with superimposed atherosclerosis. It is the first frequent site for embolism, and it is the second frequent site for saccular or berry aneurysm. So these aneurysms, they are from few millimeters to up to 2 to 3 centimeter. So they can be very tiny or they can become quite big, and they are lined by a thin wall. They are filled with blood. The wall is thin, translucent, so it can easily rupture. And these are the important complications. It might rupture. It might develop atheromatous plaque, or it might get calcified, which is called as dystrophic calcification, or it might develop a thrombus. But the most dangerous complication is rupture, and rupture is unpredictable. Usually the size of the aneurysm is more than 1 centimeter. If it is more than 10 millimeter, there is high chances of rupture, and rupture is unpredictable. It can occur at any time, but commonly seen in females. Exact reason is unknown, and there are certain predisposing factors. Any situation which increases the intracranial pressure might cause sudden rupture of saccular or berry aneurysm, and the patient will develop subarachnoid hemorrhage. And this is the image showing the subarachnoid hemorrhage. And what is the clinical course? The clinical course is patient presents with excruciating headache, severe headache, and with the first headache and after the headache, the patient rapidly loses consciousness. There is rapid loss of consciousness, and patient will collapse. And almost 50% of the patient, they will die at the first rupture. The rest patient who survives, again in the future, they have a higher chances of secondary rupture, or there is a higher chances of rupture in other saccular or berry aneurysm. Because if you read in the beginning, we have mentioned that the aneurysm might be single or there might be multiple aneurysms. So the prognosis keeps on decreasing with each and every rupture. Now the next type is traumatic. So from the name itself, it means it is because of some injury. The first one is epidural hemorrhage. And the reason for epidural hemorrhage is rupture of middle meningeal artery. And if you remember, in middle meningeal artery, it is present just behind the pterion, right? So pterion is the weakest part of the skull bone, the junction of the parietal bone and the frontal and the temporal bone. So that is the weakest part. So if there is some trauma, if there is some injury to the temporal part of the skull or to the pterion, middle meningeal artery easily ruptures. And the clinical, and this is the image showing the epidural or the hemorrhage above the dura, epidural hemorrhage, sometimes also called as extradural hemorrhage. Now, clinical manifestation is in the form of lucid interval and neurological deficit. In this condition, it is a neurosurgical emergency. So urgent decompression has to be carried out by doing Burhole surgery. Otherwise, the patient will land up with herniation syndrome, and usually the patient develops the cerebellar tonsillar herniation, coma, and death. The next is subdural hematoma which is present below the dura, in the space between the dura and the arachnoid membrane. The reason is traumatic rupture of bridging veins, we already discussed, and the reason is which has a medico-legal significance. So commonly seen in the lateral aspect of the cerebral hemispheres, bilateral in 10% of cases, and in this image, you see the bridging veins, and this is the subdural hematoma. So this was all about the cerebrovascular disease. So I think one lecture is remaining, no?
Yes, brain abscess.
Yes, doctor. And the meeting will close right now, I think.
Yeah, the meeting will close. So I will send you another link. Okay.
Okay.